Hi everyone, I'm Bryana Rivers. I'm the genetic counselor here for the HCM Center. So I'm going to talk today about genetics and family screening in HCM. I did want to start by reviewing a little bit of the genetics vocabulary to make sure we're all on the same page here. So you might hear us genetic counselors referring to things such as genotype. You might even hear your cardiologist talk about that. And so that's a person's unique sequence of DNA, right? So what is that letter sequence that makes up their DNA? But then their phenotype is that clinical picture. Okay, so we want to look at the outward expression of that genotype and how those letter changes actually impact the heart in this case. It might be things such as whether or not you have blue eyes, but of course today we're talking about HCM. A pathogenic variant we commonly use, also known as a mutation. So that's a disease-causing genetic change, or what is leading to the development of HCM. And then we have benign variants, that is a genetic cause that does not cause disease, or genetic change that does not cause disease. It is very possible to have a genetic change in any one of your genes that does not have any association with disease. And then you have a variant of uncertain significance. A lot of you may be familiar with this term. They're very common when it comes to genetic testing. And that's just a genetic change that right now the laboratory cannot tell you, is this causing your HCM or is this just a benign variant? Penetrance is something that's really important when we're talking about HCM. So that is the likelihood of developing HCM or the disease associated with the mutation. So not everyone with the mutation that's known to be associated with HCM actually goes on to develop HCM, but we know that they're at an increased risk over general population. And then you have expressivity, and with HCM that tends to be variable. So you have two members in the same family who have very different presentations of HCM, some with very mild symptoms or no symptoms at all, and some who have a very, very obvious and insignificant clinical picture. And then lastly, you have your proband. So that's a term that we throw around a lot as well. And that's usually the first person who we've started with genetic testing in the family, generally youngest age of diagnosis, or the first one who's kind of shown up in our clinic. And so the proband is the one where we will start testing with them. Okay, so a little bit more about the genetics of HCM. So it's primarily a disease of the sarcomere. A sarcomere is just a giant protein structure, and they have lots of moving parts, and it helps with the contraction of the heart. And so as you can see, with all of these proteins that make up the sarcomere, if there's a mutation in any number one of the genes that encode for this sarcomere complex, you can lead to the development of HCM, because we kind of need a well-oiled machine to make sure all those proteins are working together nicely. And so when we first started genetic testing for HCM, or when genetic testing for the first gene was identified, that was in 1989. That was the MYH7 gene, but that was more on a research level, and it was found to be an association with HCM. But the first genetic test to be clinically available for HCM wasn't until 15 years later in 2004. So there's a lot of genetic counseling that was kind of happening in the meantime, knowing that this was a genetic condition, but without being able to offer panel testing or to be able to explore, okay, what is specifically causing this person's HCM. We did see a change in the development and advancements of genetic testing technologies that were in 2011, and that allowed these gene panels to expand, and it did lower the cost of genetic testing, right? Genetic testing, I know, is a kind of scary, because I know lots of people are expecting it to be super, super expensive. It's not always cheap, but there are, we can try to usually get clearance from insurance, and it's not, $20,000 like it used to be. And then present day, there are 30 plus genes that are available for HCM and related conditions, right? So they're not all going to be HCM, but they may present very similarly to HCM. And so instead of just doing 5 genes or just doing 1 gene, we're actually going to do a larger panel. About 40 to 60% of people with HCM have an identifiable genetic cause. That range is actually, for those who have HCM and they don't have a family history, we see about a 40% hit rate on genetic testing. For those who do have a family history, that does raise to, up to about 60%. But a negative result on genetic testing does not mean that your HCM is not genetic. We oftentimes have people say, oh, no, we did genetic testing a while ago, it's not genetic. As I mentioned before, there were only 5 genes available for testing initially, and the panels have since grown, so it's possible that there is a mutation in one of those genes that weren't previously tested for you if you had genetic testing, several years ago. Or even present day, there's still sometimes we aren't really able to find that one single gene cause, but we do know it in many cases there can be much more of a complex genetics at play than just a one single gene mutation. The 2 most common genetic causes of HCM are going to be MYH7 and MYBPC3, so collectively those make up for about 50% of causes of HCM, of familial HCM. And then, we're not going to go through this whole list, but just kind of looking at the top here, you have the MYBPC3, MYH7, and then the rest of them kind of make up the other 50%. But if you see, some of these are even less than 1% of HCM, less than 2% of familial causes of HCM. So why genetic testing, right? We often hear things, I already know it's genetic, I don't need genetic testing, it runs in my family, or it's not going to change my care. Or we actually hear the other side of that, of no one else in my family has this, so I know it's not genetic. It can be important to determine what is the specific genetic cause. There are some genes associated with that thickening of the heart wall, their left ventricular hypertrophy, that looks so similar to HCM, but they're not, and they're going to have different treatment and management protocols. Also, there are some genes associated with HCM that have a much higher risk for arrhythmia and things like sudden cardiac death that we're going to want to make sure your cardiologist is aware of. And so I kind of mentioned here those conditions that masquerade as HCM. And so, as Dr. Madraza was saying earlier, there's no one diagnostic test. The genetic testing is one piece of the puzzle in order to kind of help what they're seeing clinically versus also what's coming up on genetic testing to determine, okay, what can we expect here. It also allows us to take a targeted approach to screening at-risk relatives. So if there is a mutation that's identified in the family, we do what is called cascade testing. So we're able to test parents, siblings, children. If they carry it, then test their children, so on and so forth. And so it's kind of like a waterfall, which is why we call that cascade testing. And then it also allows options for reproductive decision-making, whether that be prenatal genetic testing or even those who are going through IVF and want to do genetic testing of those embryos. And so again, we don't have to necessarily go through all this, but here are some of the more complex conditions that can mimic HCM. And so you can see that thickening of the heart wall, but it's going to be really important that your cardiologist is aware if you have any one of these number of things versus a classic HCM, because they're going to want to make sure that you're also checked in with the appropriate specialists. So family screening for HCM. Part of what we do in genetics is we get a detailed family history. We ask really strange questions. Even if someone has died in a car accident, we try to ask a little bit more information because sometimes something that seems unrelated, it could be that someone had a cardiac event while driving, or same thing with anyone, if there's any drownings in the family. So we ask a lot of kind of weird and strange questions just to really get to the heart of things, but to understand if there is, are there any red flags in that family history? And even if there aren't any, it's helpful for us to get that structure to understand who else in the family may be at risk if a mutation is identified. And so we do recommend cardiac screening for in first-degree relatives when an HCM diagnosis is made in that proband, so that first person that comes to us. So when an HCM diagnosis is made regardless of mutation status. So certainly if they're mutation positive, we're going to want to do genetic testing for those relatives. But even if they're mutation negative, just that proband having that diagnosis, we want to make sure that we're being thorough and do a baseline cardiac evaluation for those first-degree relatives. And we can capture kind of that subpopulation of people that I mentioned where there's something genetic going on, but we can't quite identify the specific genetic cause at this time. And then also we'll talk a little bit about genetic testing for children with HCM as well, and screening for children. There are screening recommendations for children, but I know there's going to be a talk about that later, so I won't get too much into that. We just talked a little bit about this, so just touching back on it. If a pathogenic variant or a mutation is identified in the proband, we do recommend cascade genetic testing for at-risk relatives. If for those relatives who test positive, we recommend that they establish care with cardiology if they have not already. But it's important to know that a positive result in an unaffected relative does not diagnose them with HCM. We know that it means that they have an increased risk to develop it, but it does not mean that because they're positive on genetic testing that they have a diagnosis of HCM. That would be made with a clinical evaluation if there's any changes on their screening. And then if that at-risk relative tests negative, but we already know what the mutation is in the family, there's no real need for them to do any longitudinal screening unless something separate comes up for them, right? That doesn't mean that they're completely immune to any cardiac event in their life, but just we know that they did not inherit the risk factor for HCM in the family. And just kind of that reminder, as we talked about earlier, that negative genetic testing does not mean not genetic, so that's why we'll still make that recommendation for first-degree relatives through screening, even if you see me or see a genetic counselor and your results are negative. So when we're talking about HCM, the majority of the genes that we're going to be looking at are inherited in what is called an autosomal dominant fashion. So we often hear patients ask if it's expected to skip generations, which it is not. It just means that if we have 2 copies of each genes or 2 copies of most genes, and so if you have a mutation in one of those 2 copies of the gene, that is sufficient to cause HCM. And then every time you go to have a child, it's a flip of a coin. So there's a 50-50 chance whether or not you pass on the copy with the mutation or pass on the normal copy. And so we've also had, whenever we mention the 50-50 chance, we've had people say, okay, so if I have, 4 children, 2 of them are going to have it, 2 of them are not. It doesn't work that way. It's every single child has their each individual 50-50 chance of having shared that. And we also want to make sure that it's important for people to know that your age and severity of diagnosis is not always going to be a good indicator of the age of diagnosis for your relatives, which is why even if someone doesn't present until their 60s, we're still going to recommend some screening for relatives who are younger because we can see adolescent and childhood onset in some cases, even in that same family. So when to test children. For children who have a diagnosis of HCM, we do recommend genetic testing at the time of diagnosis. For unaffected children of a parent that has a known HCM mutation, we usually work with families to see what they're comfortable with. We still want to make sure that they're getting their cardiac screening, but when it comes to the genetic testing piece of things, there are life insurance considerations. We make sure we talk about that with families. Some people say, you know what, I just want to know. We'll cross that bridge once we get to it. Some people kind of decide to wait on the genetic testing piece of things. It's different for every family. I do put an asterisk there because if we do happen to, in a particular family, see childhood onset of HCM, we are going to kind of lower that threshold a little bit and be a little bit more concerned. And so we may be a little bit pushier in our recommendations for getting that genetic testing done sooner rather than later, just to understand what that child's risk may be. And then I talked about this briefly earlier, but yes, prenatal genetic testing is an option. And so we do work very closely with a team of prenatal genetic counselors here. And we provide them with genetic test results, recommendations, whatever they need. If a patient would like to do prenatal genetic testing, so while they're pregnant and they want to do diagnostic testing in utero, that's an option. Some people wait until after the child is born to do the genetic testing. Again, that's also a decision for the family. And then lastly, the same is true for preconception genetic testing, and we certainly do that all the time. There are people who prefer to screen their embryos, and so we have those conversations, work with IVF laboratories also to make sure that we're coordinating testing for appropriate family members, as well as providing them with sufficient information. So kind of finishing up here, the future of HCM genetics, I talked about kind of we are in this zone of single gene mutation testing, and that's kind of where we've been able to do a lot of our diagnostic testing. We do know that it's not always so simple when it comes to HCM. There's a lot of multigenic causes and factors. Environment can play into that as well. And then polygenic risk scores are something that might be coming about in the future. We know that we've seen them with other genetic heart conditions, but that is basically an additive, like smaller genetic changes that have an additive effect to make it more or less likely for you to develop HCM, and that kind of puts you in a risk. So low risk, mid risk, high risk, as opposed to more of a defined risk that we can sometimes see with the single gene testing. Okay. So that is all I have for you today, and I really do appreciate your time.